All right, well, we'll go ahead and get started for day 3. So, welcome back. Still got people kind of trickling in, which is good. So, hopefully you got some coffee or some yogurt or something else to get you going. So, just want to give you a few announcements of things for today with our half day. So please remember to vote for your favorite poster presenter using that Qualtrics survey code, the QR code you've seen flashing up on the screen during the poster break. And then the poster presenter with the most votes will be announced at 11:05 and will win a swag bag prize. Ding. Additionally, we'll do a raffle drawing during the 11:05 session using the raffle tickets that have been handed out to you who have been actively engaging in the poster sessions. And the winner of the raffle drawing will also win a swag bag prize. But you must be present to win. So you have to be here. Poster presenters and poster faculty evaluators, we will have one more poster session, if you're here, today from 9:25 until 9:50, so during the break period. Presenters who are still waiting to be visited by all 3 judges will need to make sure you are standing by your poster during that session, okay? And then the first place scoring poster for both master's and doctoral level will win a $300 Visa gift card. And the second place scoring poster for both levels will each win a $200 Visa gift card. And then, so remember, poster presenters, take your poster with you at the end of the conference. And I believe that's about it. So with that said, we've got some good speakers this morning from UAB, Kentucky, UNC. So should be some good sessions during this first part of the morning. So we'll kick off with our first pilot project research training program presentation this morning with Dr. Mike Callahan from the University of Alabama, Birmingham. And his presentation is titled Measuring the Impact of Secondary Stressors on Patient Outcomes Through Simulation.
While she's getting this queued up, I brought a student with me, and she's going to do most of the talking because
he gets all the credit, I do all the work.
I get the credit, she does the work. So I'm Mike Callahan. I'm from the University of Alabama in Tuscaloosa, but we were attached with UAB for the pilot funding, and hopefully I can get some more money out of Claudio in the future. So we're talking about measuring the impact of secondary stressors on patient outcomes. And you may ask, what does this have to do with occupational health and safety? Well, we've realized that hospital administration doesn't really care about the well-being of a nurse, but they do care about patient outcomes. So if we can link the well-being of the nurse to the patient outcome, then we can possibly even make a difference with them. My research team, this is Stella Rogers. She is graduating here in a couple months. She'll be going up to the Mayo Clinic in Minnesota. She'll also be in the market for a PhD program, so if you want her, trying to pull her in. We received our funding through the ERC, the Deep South ERC. And we want to look at how these secondary stressors impact the nurse's performance. We want to talk about the complex simulation that we conducted with these nurses, and then look at some outcomes from that.
I'm going to apologize ahead of time. I neglected to take a public speaking class, and I'm not used to being awake with the sun, so forgive me. Okay, so when we think of secondary stress, first thing to come to mind is usually PTSD. And when we think of PTSD, at least for me, first thing to come to mind is our military service members. But this isn't always true. They're not the only people that can experience post-traumatic stress disorder. Anyone who is in contact with any type of trauma can really experience it. And for nurses, this is secondary stress. It's they're not directly living the trauma, but they're experiencing the same effects while they take care of it. We see this in ER nurses a lot, and this leads them to experience the emotional effects that you can see, not sleeping, flashbacks, all those good stuff. And we're seeing that this secondary stress is leading to PTSD, burnout, and compassion fatigue, which is, we don't want that to happen because the two important things in nursing is compassion and critical thinking. When you don't have either, you're not really doing nursing, you're just a monkey doing tricks. So ER nurses, they see a range of patients. They can see anything from a toe pain patient, stomach bugs, to gunshot wounds, stab wounds, car wrecks, all at the same time. And they can't really control how many patients they see at one time. And with all these stressors, this causes them to miss cues in their patients that can lead their patients to deteriorate. Oh my gosh, words. Deteriorate. And when they miss these, they can kind of look back on it and what are the words I'm looking for? They'll look back and kind of think, what did I miss? What could I have done better? And this will cause them to kind of feel like it's all their fault and experience that secondary stress that we were just talking about. When patients come into the hospital, these are the first nurses that they also see. So it's not like they can turn them away and not see them. The ER nurses, their job is to stabilize the patient. So if a patient's not going to be able to be stabilized, they're the ones that are going to see that patient deteriorate and not make it. No one else. It's going to be the ER nurse. So for our study, we utilized a complex simulation. Simulation has been used in training nurses for a long time now. It's been found to help with developing nursing skill sets and their knowledge, and allowing nursing students to develop the confidence to take care of patients in real life. So the difference with our study, though, is it was a complex simulation. So instead of focusing on one patient scenario, we had multiple patients. We used both mannequins and real-life actors, which added to the concept of realism. We tried to turn the simulation lab into an ER, and it was the coolest thing ever. We had monitors that beeped. We had actors that acted like doctors. We had the walkie-talkies that you would use as your pager system. So we did a really good job of trying to create an ER outside of the ER so that our nurses could make mistakes and it not actually affect anybody. In our simulation, we had 4 different patients. The one I was in control of was our pediatric patient. It was a mannequin, so it was really cool to just be able to talk through the mannequin and mess with the nurses. But he had an asthma exacerbation, and he was stable and just waiting for a bed. And then another patient that we had was a young adult with a headache, elevated blood pressure, and after about 35 minutes, they experienced a stroke during the simulation. This patient was a real actor in our simulation. Our third patient was our middle-aged patient. He came in with a new onset of chest pain and a low blood pressure. It was supposed to mimic kind of a heart attack patient. And so with our different groups, we had an experimental group and a control group. Our control group only received 3 patients. Our experimental group, they received a 4th patient after 25 minutes to kind of add on to the stress that you would see on the ER. Like I said, you can't really control how many patients you're seeing at one time. So our 4th patient that we would add on to our experimental group was an elderly patient. This was it was a live actor, and he just came in with flu-like symptoms. Like I said, that stomach bug I was talking about earlier. And so his job was just to distract the nurse and ask for water, ask for a bedpan, ask for anything on the planet that he didn't really need to save his life at that moment. So we recruited from our local hospital in Tuscaloosa. We had 18 participants. We had 13 who had less than 5 years of experience in nursing, and all of these participants only had an associate's degree in nursing. And then we recruited on another 5 nurses who had greater than 5 years experience to kind of validate our findings. And 3 out of 5 of these patients had a bachelor's of science in nursing, but we found that had no effect whatsoever on our results and on their decision making. It was more the stressors, not their level of experience or their degree. So we added stressors just like you would in the ER, or just you wouldn't add them, it just kind of happens. And our goal was to see at what point the nurses were no longer making appropriate critical thinking decisions. At what point they just stopped thinking at all and were just doing tasks instead of thinking about it. So like I mentioned, with our experimental group, at 25 minutes, we added a fourth patient. And this patient was added just by random, and it just randomly was assigned to all of our senior nurse groups, so the ones with greater than 5 years experience. And then at 35 minutes, this is when our young adult patient with the high blood pressure, their oxygen dropped, their heart rate increased, and their blood pressure increased even more, which was an attempt to simulate what would happen with a stroke. And so the alarm sounded so that if the nurse was in another room, she would hear that something was happening and would have to go find what was happening, where it was happening at, and our real-life actor pretended to become unresponsive. We actually had a defibrillator machine in there, and we had to run in there and stop her from actually using it because it actually works. All right. So what we saw with our patient outcomes on our fake patients, on our chest pain patient who was the middle-aged adult, this was the priority patient for most people. They got to choose which patient they saw first after getting report, and most people chose this one. 12 out of our 13 junior nurses and 3 out of our 5 senior nurses. Remember I said they had the low blood pressure already. So a bunch of the nurses started doing interventions without actually assessing their patient and taking into consideration that they had a low blood pressure. So they were giving them nitroglycerin, which is appropriate for chest pain. But with a low blood pressure, you're wanting to correct that blood pressure first before you administer that. Otherwise, it's going to drop it even more. And with no blood pressure, you get no blood flow to anywhere in your body, which is not good. No blood, no life. So we saw that. They gave the 2-nitroglycerin. They also gave metoprolol, which slows the heart rate, but it also lowers the blood pressure. And then we also had one nurse who gave morphine, which wasn't even in our order set. This is a big deal because in the ER, nurses have access to any single med that they can get their hands on. They don't they don't have like a lock and key that they have to go through. So giving morphine without an order is a big no-no in the hospital whatsoever. On our young adult patient, the stroke patient who deteriorated after 35 minutes, one person missed the stroke completely. They didn't acknowledge the alarms, the change in vital signs. They just kept going about what they were doing. And this isn't good. A stroke is something that you want to get to in a timely manner to kind of save as much brain tissue as you can by getting to it quickly. The high blood pressure, when they came in, they already had high blood pressure, and a lot of nurses didn't even correct this. They just kept going about their day, or it was only like a 45-minute simulation, but they kept going about their 45 minutes and without addressing it. And then we also saw limited neurological assessments. Only one nurse performed the NIH stroke scale, which is standard to see where the patient is at with their stroke, to see what kind of effects it's having. And even then, they weren't that confident in performing the scale on the patient. So clinical implications, like I was saying, we are seeing that our nurses are needing an improvement in their assessment skills. Without good assessment skills, their treatment suffers, or the patient's treatment suffers, at least fast treatment. We saw no blood pressure assessment, no critical thinking with how to fix that before they gave any medications, and then no neuro assessment in our stroke patient. We saw nurses basically going into protocol mode and just doing what their normal order set is instead of taking into account that each patient is unique and can have different factors that go into their treatment. So that's where I was talking about the two most important things in nursing is compassion and critical thinking, and we saw in the study that nurses are missing both of those. They're missing their critical thinking skills, which are causing the patients to deteriorate. And because the patients are deteriorating, the nurses are experiencing secondary stress. And because of the secondary stress, they're lacking compassion, which is the biggest thing we need in nursing right now.
One important thing to take out of this, of 18 nurses, 9 or 10 of them would have actually killed their patient. And when you start looking at numbers like that, that's a big deal. Because of giving extra medication, not finding things, good chance of really negative outcomes. So the second part of our study was actually doing qualitative interviewing with nurses about PTSD. We did 13 interviews. We had 8 females and 5 males. try to get a good diverse population with making up different racial backgrounds, gender backgrounds, and from the hospitals that they were from. We initially had them take the PTSD survey. So they'd get in, they'd do the survey. That scores anywhere from 0 to 80. Anything over 60 is going to be very severe symptoms. When we looked at the results, we had a maximum of 56. So we had one nurse that had very severe symptoms. Our lowest score was 10, so that puts them at minimal to mild symptoms. Most of our nurses fell in that moderate symptom range when we looked at it, or mild to moderate range. When we talked to them, there were several different themes. And I will say, I read every single one of these interviews and started doing the analysis, and it broke my heart. Nurses from 6 months experience all the way up to 19, 20 years experience that were just totally wiped out. We had a nurse with 6 months experience said, nobody is supposed to feel like this. And yes, COVID was going on at the time, but it was a beating that these nurses shouldn't have had to go through. I take this very personal because last Friday, we sent off a friend of mine that I've worked with for 20 years. I've known him for 20 years. He decided to take his own life because of the PTSD he's experienced from emergency care. And this is something that we're seeing with nurses, critical care nurses, first responders all around the country as they're deciding to fall to their demons because of what they're going through. There is a lot of aggressions toward nurses. Had one nurse say, it's just normal for us to get assaulted. That's not acceptable, but it's become accepted practice within nursing for nurses to get assaulted while they're taking care of patients. Life outside of work. I had a couple of the nurses say, I've lost all kinds of relationships because of work. I leave work, I'm just mad. I'm angry, I'm yelling at people. My parents are begging me to get a different job. My family, my friends, all of them wanting to get a different job. A lot of ER nurses fall into negative coping mechanisms. We see a lot of alcohol abuse among nurses. And then just the time to actually do anything outside of the workforce. Granted, with COVID, we were working 50, 60 hours a week every week. And that looks different than a lot of places because at 50, 60 hours, you're actually up running the entire time. So coping mechanisms really became a problem for us. So the things that we saw, the simulation was very well received. The nurses loved it. They begged us to do more. We have 3 other hospitals across the country that I've talked to that actually want us to come in and help them build this simulation for their ER staff. Because our ER nurses are saying, we're not ready. We're not prepared. We need this kind of training to really get us up to speed. Both the junior and the senior nurses have given us this feedback. We see a lot of PTSD among nurses, whether it be ER nurses, ICU nurses. They're really taking a lot of mental abuse right now, and quite frankly, we failed them. So we really need to put more effort into them. And by we, I'm saying me. I failed them. So we've got to change something. We have to start improving the way that we're preparing these nurses, and we have to give them some type of mental release from what they're going through right now. COVID hit us all, but us ER nurses saw a lot of things that most of you just read about in the newspapers, and we're still suffering from it.
So, hi, I'm Joshua Yang, USF. That was an excellent talk. I really enjoyed it. I spent some time in trauma centers too, so I know what the nurses go through. And first of all, I want to say the nurse is a very important part of patient care. When providers spend maybe 5 minutes a day, nurses spend the entire day with the patient. I think you guys are a huge part of patient psychosocial aspect of the patient well-being. That being said, that simulation that program you guys have, I really think that that's really crucial to learning. You know, in medicine, we say you see one, you do one, you teach one. And I think that's an excellent idea for all the nurses to take. That being said, my question is, why do you think, in your opinion, through your research, that nurses lack analytical skills? Is it, I mean, that's data that I saw where 4 out of 5 nurses gave nitroglycerin to a hypotensive patient in a trauma setting. That's really surprising.
Yes, and what we found, these nurses, if we're doing just one-on-one simulation, their critical thinking ability is through the roof. But once we start adding all of these other distractors to them, the critical thinking kind of goes out the window and they fall right into protocol mode.
Right.
Over the last couple of years, I've seen that among physicians and nurses, where they're just getting overwhelmed and you fall into protocol mode. We don't train physicians or nurses to handle all of these stressors appropriately. Because it's typically, with simulation, as you know, we typically have one patient. It's going to be like a low incident, high acuity patient that will really focus on getting that knocked out. But we don't have that person that's yelling from the other room saying, hey, I need some pain medicine for my stubbed toe. So I think building this, and as we build further, we're actually bringing physicians in to add that to it as well, because we need to really be prepared for all of those additional stressors.
Right. You know, the preparation, the better communication with the physicians maybe. Is there a reason, maybe part of the reason is nurses tend to kind of fall back to protocol, and maybe there's a fear of, you know, if it's a teaching hospital, there's a resident there, right? So you kind of, you know, I don't want to be decisive. I don't want to make the decision. Let somebody else do it. Is there, you know, is there some of that, some fear factor of if I do something wrong? And that kind of steers away from analytical thinking.
Litigation is becoming a big thing in emergency medicine. And that goes on both the physician side and the nurse side. Because of all the litigation, we have to checkbox. We talk about it a lot, checkbox medicine, and we're seeing that.
Yeah.
They come in, they have a low blood pressure. We know it's a low blood pressure because of some other reason, and we're doing full septic workups and giving them antibiotics. So we're doing a lot of things based off a checkbox, and litigation is the driving factor for most of that.
How did you assess their buy-in to the simulation? Because I'll admit, the only thing I've ever seen with simulation are like the way they do it at like games places. So how did you see if? I guess how well did they buy into it?
I can do it.
Okay, go ahead.
So you're kind of asking, like, how did we see what they were doing in the rooms?
Well, no, like, right. You may act differently in a real life setting versus something that you know isn't real, right? And if you're not really clear on what you're being assessed on, then maybe they're prioritizing things differently in a simulation than they would in real life.
Yeah, and I think that's a problem with any type of simulation that you do is they kind of in the back of their head know it's not real, which is kind of the good thing about it is they know they can make mistakes. So you can catch those mistakes before they're making it without knowing it.
And with every simulation, we have a debrief at the end. So they come in, they sit down. I did the debrief on every single one of these. And we'd have the conversation with the nurses. They also filled out a survey at the end about realism and different pieces of the simulation. So we can't really simulate and make them truly feel like they're there, but every single one of the nurses said that was the closest thing to real life that they've ever experienced, other than actually being in the ER.
Gotcha.
So a lot of that was just qualitative data to determine their buy-in from it.
Gotcha. Thank you.
I have a part to add to that. I remember what I was going to say. I had a little brain fart. Yes, so you could kind of see too when they came into the simulation rooms, they would get report and kind of like how you would in the hospital on a basic rundown what was going on with each patient, and you could see like from before they were inside that door, they were smiling and happy and just like talking like we are now, and then you could kind of see them get to work. Like you would see that in their face. They kind of just went into work mode. So I feel like that they did as best as they could into treating it like a real ER.
This whole concept of the simulation in healthcare is really intriguing to me. And there's several people here that have policy and background and healthcare administration sort of things. How would that work? And it's as a follow-up to kind of what Courtney was saying. I've never done this in a medical setting, but the people that run our nuclear power plants have to get a simulation recertification every 6 months, and their job depends upon it. The scores that they get determine whether they get to continue in the field. I'm not saying that we want to do that to nurses, but I would think that if it's tied to some sort of employee evaluation, that they would take it very, very seriously. It'd be very close to, I mean, when I watch these guys in the nuclear power plant, it looks really real because they know if they screw up and the reactor crashes, they fail the test, and it could mean their job. But I bet they take it pretty seriously. How would it work logistically? How do you think we could do this in our hospital settings?
Logistically, it's interesting you mentioned the nuclear power plants. I worked on a nuclear power plant on a submarine before in a previous lifetime, it seemed like. And we went through those operational readiness tests twice a year, and they were absolutely brutal. But in the nursing setting, we could do this. We're talking about in situ simulation in a lot of places and how we're advancing that. So we can set it up where they actually have a simulator put in a room, and then they'll call a code in that room. And all the nurses have to go in and they run through the code. So a lot of your emergency departments, we could actually set up different areas to do that and do that on shift with some of the nurses. We do every year have to do competency testing as a nurse, so we go over all these fine motor skills, building in that simulation into that competency testing, and having some type of grade scale would definitely be manageable and doable in the healthcare setting.
All right, we're ready to go. Next up, we have Dr. Courtney Walker, who's a postdoc, I know with the University of Kentucky in School of Medicine, but the specific program.
All right, so today we're going to talk a little bit about, here we go. Geocoding, birth records. What is geocoding? Why does it matter if it's precise? And then kind of some exploration we did using vital statistics records in Kentucky. All right, so place matters in health, right? It impacts the air you breathe, the water you drink, the food you eat, the school that your kids go to, the ability for your kids to go and play in parks, whether or not you can hike, right? Place matters. So how do we get information on someone's place? The easiest way, especially if you're doing primary data collection, is to ask, right? But if we don't ask, most of my research is focused on secondary data analysis, we can pull it from records, right? So medical records, when you go to the doctor every year, they give you that giant stack of papers. What's the second thing you put after your name? Where you live, right? Vital statistics as well. So birth records, death records, marriage records, all of those things you record your address on because they need to know where to send stuff to you. Disease registries, not all disease registries. I don't think the tick registries tend to catch address, like maybe they get where someone had the tick removed. But cancer registries do. They capture the address at the time of diagnosis, which is great for things like short-term lag, like pediatric brain tumors. Not always so helpful for things like lung cancer, which tend to have a longer latency. And then LexisNexis. So when you go through and like you're verifying your identity for a loan and they ask you like, did you live in this address, right? Some places will purchase that information from LexisNexis, and health researchers can as well. They comb through public records like when you got your fishing or your hunting license or got married, right, to build this database of residences tied to someone's name and social security number, right? So what is geocoding? Geocoding is taking an address and plugging it into a program that will assign geographic coordinates, which is latitude and longitude. The precision of these coordinates may vary though. The ideal precision is at the point level. I know where your house is. That's a little fuzzy. We can get into the weeds on that if you're interested. But for now, keeping it simple, right, where your house is. The next, pretty good, still precise, not my favorite, but decent, is a street segment. So for example, I live at 159 Ransom Trace, 40324 is my zip. Say my database has 158, or my reference data set rather, has 158 and 160, and they're like, well, 159 is in the middle of that. I'll assign the geographic coordinates to that. That's cool, right? Close enough. You move into less precise when you get to the midpoint of a street. Now, some streets are really short, and that's fine. But then when you have streets like 25 in Kentucky, if I'm not mistaken, I don't predate the interstate, so maybe the folks that do can correct me if I'm wrong. 25 used to be the old interstate, and I believe it runs from Michigan to Florida, right? So 25 will actually span the length of a county, so can zip codes. So if someone geocodes to the center of 25, that's not particularly helpful because that can be miles away from where they actually live. So then you move to even less precise, the midpoint of a city or the midpoint of a zip code. For some, like if you're looking at calculating prevalences of a county or a census tract, it may not be that big of a deal. But if you want to know where they're getting their water from, how far away they are from a factory, it does matter. Right, so there are some geocoding challenges. There are size limitations, at least to the program I use, which is Esri. You can only geocode about 64,000 records at a time, which sounds like a lot, but when you're working with 1 million records, it can take a while to geocode. There's also recording errors, right? There's a big difference between a drive, a lane, a terrace, a boulevard, right? It matters. Ransom Trace is on one side of town, Ransom Lane could be on the other side. You mix that up and someone's geocoded to the opposite side of where they actually live. Rural routes and hired contractor routes. Those aren't as big of a deal now as states are moving toward what's called E911 addressing, where they're standardizing addressing so that they can more quickly send first responders to a specific location. But it's when you work with historical records, it can be a challenge because we may not have the geographic coordinates of some of these rural routes, and those folks would get their mail from a post office box anyway. And there's also the road name changes. So again, E911 addressing, they're changing addresses where, like for example, someone paves their driveway because the county will cover it. They have enough houses living off that driveway that they can. And they just picked random numbers, right? So I'm gonna live at 367, Fannie Mae Lane. E911 addressing says you can't do that. Your house number has to correspond to how many miles down the road you are, roughly. So then that may change. Some counties do a really great job of tracking these changes and even making sure that they don't recycle road names. Lexington and Louisville are two of those places. Other places, they're barely keeping their heads above water trying to get the E911 addressing off the ground. They have no idea. And then there's also issues with spelling and pronunciation, right? Like we're all familiar with the Louisville, I don't know how you guys say it wrong, but it's Louisville. But there's also places like Barville. If you look at how it's spelled Barbersville. But if you get somebody from Lexington going down and interviewing somebody from Barville, they're going to say Barville, and that's what's in the record. I know that because I worked on data where they had recorded information from folks who lived down there, and there was a lot of B-A-R, not Barber. But anyway, and then, spelling and pronunciation. There's also the Versailles-Versailles one, or Athens, right? So there are challenges in public health too, right? Missing information impacts everything. So there's a lot of holes in their data sometimes, like Swiss cheese. There's also the issue with cross-sectional data, right? Like we capture everything about that patient only once, or we only have a snapshot. Birth records are recorded at the time that a baby is born. It's not like, well, they do kind of follow up if there's a death in the first 28 days. But like the demographic information, they don't necessarily go in and fix information if it's wrong. There's also issues with identifying record locations and geocoding bias, which we'll get into in a minute. So in order to kind of get an idea of whether or not we could use birth records as a way to assess disease prevalence, we wanted to see if we could actually find the addresses pretty well. So we wanted to assess the precision, and we also wanted to see if there were any factors that we could identify that may be associated with geocoding and precision. So when you think of birth certificates or birth records, you think of, that's my son's birth certificate at the bottom, right? Like you get this in the mail, it has your kid's name, your name, how old you were when you had your kiddo. Right, but the white form on the top is what most people actually fill out, right? And there's front and back. They capture everything from where you want your birth certificate sent to whether or not you had a cerclage, whether or not you tried to have a vaginal birth before going to a C-section, infections, all that stuff. And all that's recorded at Vital Stats. So I had to get permission not only from the University of Kentucky IRB, the state had to approve this research as well. I got data from the 2003 Certificate of Live Birth. Not every state, now every state does, but that wasn't true until 2015. I also used USDA RUCC codes and then what's called an Area Deprivation Index. It's this score that kind of assesses the level of deprivation within a census tract. So it adjusts for things like median income, average college education, and a few other things. And then we looked for people who were self-identified Kentucky residents, which is kind of tricky. Your residency is determined by where your driver's license is almost, right? So like you can be from Kentucky, but if you are living, voting in California, you're not a Kentucky resident. We had issues with that. And I did restrict, so we excluded all of the twin records, right? Because I couldn't link the records to the mom. So to reduce the duplication of addresses, I did exclude twins. All right, so geocoded with Esri Address Coder. I don't know, I keep looking over there. Made maps with QGIS. All of my analysis is performed in SAS, and I meant to take this out. All p-values below 0.05 are considered statistically significant, but I don't report p-values because I'm an epidemiologist and I like confidence intervals. A lot. All right, so this is kind of the breakdown. 90% of our addresses were high coordinates or high precision. About 10% of those addresses were low precision, but they did geocode to a city or to a zip. Only 10 were unable to be located. Right, so the first thing we needed to know was how this has changed over time. Right, so at the beginning of the study period, which was 2008, 40% of records in rural locations did not geocode precisely. By the end of the study period, it was down to 1 out of 4. So that's not terrible, but it's better. Urban areas, Lexington and Louisville, stayed fairly consistent. They have a really robust GIS program, though. Right, so this kind of gives you an idea of the bottom map, or the gray map. That shows you where the urban areas are in Kentucky, because not everyone has Kentucky transcribed on their heart. I won't judge you too harshly for it, but gosh, what a great state, right? So the area that's kind of outlined in black is the Appalachian region of the state. And the upper map, the blue map, shows you where we had the areas with the highest precision. So the dark blue are in the more urban areas. You can see, if I can do this, right up here is northern Kentucky. Over here is Louisville. In the center is Lexington, and down here is Bowling Green. So they do a good job, right? But there's this whole chunk of the state that is kind of problematic. Right, so there's a lot of numbers. The numbers themselves, right, raw numbers, those are the number of folks. The numbers in the parentheses are the folks, the percent of folks within those groups that did not geocode precisely, right? So this is kind of what we would expect to find. Practice effects impact a lot of things, right? So folks under the age of 23 who were giving birth, maybe for the first time, right? They've probably never seen these forms before, so yeah, there's a higher proportion of those folks that may not have geocoded precisely because they were a little busy, so maybe they didn't pay as close of attention to their paperwork. And then the folks that had an unknown birth or unknown maternal age, right? So maybe there were other mistakes if they didn't capture maternal age, other issues there. There were other issues there. We noticed in urban areas that white women had a higher proportion of not geocoding, but in non-urban and rural areas, it was women who identified as an other race. The reason why these were collapsed is because there were really low cell counts. So mother married, you'd think having a partner in the room would make sure, like they double check things were filled out correctly. Apparently not. This was pre-COVID, right? Like they didn't have any other distraction, well, other than, like having a kiddo. And then missing ADI. So some areas, some census tracts did not get assigned an ADI because they were either really, really rural. There was only 1 or 2 houses. There wasn't enough houses to really be able to calculate this. Sorry, excuse me. Or there was like, the census tract was kind of dominated by one housing structure, like a really large low-income housing unit. All right, and then kind of what we expect, right? What we saw on the map. The Appalachian region of the state, regardless of what its RUCC code was, did not have a had the higher proportion of folks that did not geocode precisely. So nothing new, right? When we did the logistic regression, right, so we adjusted for things like age and what else? Race, ethnicity, education, maternal BMI, infant birthplace parity, prenatal care, all of these things. What we ended up finding was that, yeah, what we expected. Older women had a lower odds, or hold a second, I can't see. Yeah, they had a 17% reduction in the odds of geocoding imprecisely. That was statistically significant. But in even if they didn't capture the mom's age, it didn't really matter as much in urban areas. But in non-metro and rural areas, it did, right? So those folks had a 19% and 16%, although it wasn't significant in rural areas, increase in the odds of not geocoding precisely. We also saw some flips. So in the urban areas, Black mothers had a reduced odds of geocoding imprecisely. So they were more likely to be found, right? In urban and non-metro, or rural and non-metro areas, though, that was not the case. Although it was only statistically significant in rural areas, right? So they had a 41% increase in the odds. And ADI matters too. Mid-range in the urban areas, I don't really know what's going on there, I'll be honest. But if you look at the highest areas of deprivation in the state for non-metro and rural areas, there was a substantial increase in the odds of not being able to find these folks. And Appalachia kind of goes along, right? So 20% increase in the odds. And kind of going back to that line chart we saw at the beginning, things remained fairly stable in urban areas. There wasn't a lot of change in precision over time. But when you look at non-metro and rural areas, there was a decrease, which is good. That's what we would want to see. Right, so what did we find? Rural areas have a larger proportion of imprecisely geocoded addresses, kind of expected to see that. Not at such a large quantity though. And then there were notable geocoding differences among the metropolitan strata, right? So race and impoverished areas, what we saw kind of varied. There are some limitations. So one of the things that I did find out is hospital data collection practices vary. So when I gave birth to my children in Lexington, they handed me a stack of papers and was like, "You're not busy, fill these out," right? At my sister's hospital, she gave birth, in London, Kentucky, they pulled all this information from her medical record. Like, well, that's really cool. Why couldn't they do that for me? And then they have different procedures for checking this data, right? Hospital registrars are the ones that send it to Vital Stats, and then Vital Stats will do some checks. There's a lot of babies born, things that were a little busy, right? They don't check everything for everybody. There's also the issue of adoption, right? So for folks that have been adopted, when you get adopted, you get issued a new birth certificate with the name of the person that adopted you. And the original people on your birth certificate are no longer there, right? Those are locked away. I don't get those. I get whatever's on file at the time. So Kentucky has a high proportion of grandparents taking care of their grandchildren. Mom and dad may actually be Mama and Papa. And that would be the address that I would geocode. And then when you have like same-sex adoptions and things like that, same issues, right? They may change the address. So precision matters, right? Depending on what you want to do, it may not matter all that much. If you're wanting to look at county-level prevalences of a disease, if they don't geocode super precisely, that's probably okay. They're most likely going to be within the bounds of their county. But if you want really precise information, like if you're doing disease detection clusters, like this study up here, right? This was a cluster of early onset hypertensive disorders of pregnancy. One, it's huge. But two, I don't really know how accurate that cluster is because if people aren't geocoding precisely, I'm not sure I can trust it. Whereas here, I can feel okay, right? And in this study here, we were looking at cancer histologies. Now, for the Cancer Center, they have someone else do their geocoding. I think it's someone out of Texas. But if we're looking at census tract level estimates of cancer prevalence, there's a chance that they may not be in the census tract they're actually assigned to. And then this is a study looking at obesity and sprawl. So this is an indication of population density. And then we were looking at green spaces, I think. Or even in this study, these are mountaintop removal sites. If we wanted to look at the distance from a mountaintop removal site from a person's house, all of these are in eastern Kentucky, if we can't find these people when we're trying to figure out how far away they are, it's going to be inaccurate. So place matters, right? We could misassign them. So instead of saying that we may say they were exposed and they actually weren't. They need to be down here, or vice versa, right? So then when we're trying to look at the impacts of some sort of exposure and disease, we're going to get it wrong. All right, so future directions, some of the things that we're working on right now. Kentucky has 120 counties. We're trying not to go to every county, but capturing information on historical addressing over time. We're also trying to identify the times and the places that aren't geocoding precisely. So, say for example, there was a low-income housing unit that got demolished. People still had their birth certificates sent to that unit, but if it's no longer in existence, it's not in my current data set, so I can't find it. So we're going to try to identify the zip codes and then reach out to those communities and get information on where that was. And then identify more geographic characteristics associated with poor precision so we can do a better job of finding these folks. All right, so thanks for the pilot funding, Wayne. I appreciate it. The state was also incredibly helpful. Oh, and my undergrad also funded some of my time to work on this project as well. And then my PhD committee, this is part of my dissertation. Dr. Browning, Dr. Christian, Dr. Sanderson, among other folks, were immensely helpful, and I'm super grateful for their advice and their support. Any questions?
Good morning. So, when one goes into the hospital to deliver one's child, the information that you got stacked upon you since you had so much free time on your hands, did that include occupation of mother or father by any chance?
They removed that in the 80s.
So that's gone on any kind of ED or hospital?
I can't speak to ED records, so this is the information that was sent to the state. Hospital discharge records are completely separate.
And is that a state phenomenon or is that sort of national, do you think? In terms of no longer collecting that type of data?
On the birth records?
On birth records, yeah.
The entire United States uses the same birth record. The form that I used was approved in 2003. And Kentucky was one of the first adopters of that. But by 2015, states may have been using the 1986 version. I'm not sure if that version had occupation on it. So it may have been removed in like the 60s or the 70s birth record, but it's not been there for a really long time.
The lack of accuracy on the rural compared to the urban components of the data sets, what do you attribute that to?
There's a few things. One, so urban areas have more resources, right? They can set up independent GIS offices. They can go out and send folks to accurately get the geographic coordinates from a house as it's being built. In some of these rural areas like Pike County, the Kentucky State Police handle it. Or in some other organizations, so we have these what are called area development districts or AD districts. They may assist a county if they need help addressing. There's a lot of inconsistencies with how this GIS information is recorded. Also, one of the issues too is property value assessors or PVA officers are elected positions. You don't have to have anything besides a driver's license to do this job. Some of those folks have GIS skills, and as folks are purchasing land, they'll go out and geocode it. That's what happens in my home county of Whitley County. That doesn't happen in every county, though. So I think a lot of it's just there's not a consistent approach for how we actually record residential information, street information in some of these more rural areas. So then what ends up happening is we can't get an accurate picture of where people live. And it hurts, right? So it hurts research when we're trying to look at disease clusters, but it also hurts dispatchers because they don't know where to go. They're working on fixing that. So supposedly in the next 4 years, they're going to create a statewide EMS database where they can centralize dispatching locations. So someone from Western Kentucky can dispatch EMS in Eastern Kentucky, but we'll see where that goes. Did that answer your question?
Yes.
I actually have one question,
Okay, cool.
Courtney. Do you have a question? Well, come on up, and I'll ask mine while you're coming up to that mic. Excuse me. So this is one of the reasons I tell my students, two of your best friends to have are epidemiologists and biostatistician
Oh, thanks.
to deal with these kind of issues. Yeah. But so we think about, so if there's I'm going to the presentation yesterday, an aluminum smelting operation in the state, and you're trying to track some type of disease clusters or if there's prenatal, early
Looking
term
at birth
deaths.
defects associated
Yeah.
with that industry, right?
What advice do you have for us on the occupational safety and health research side when considering the use of this kind of data?
I would ask who's geocoding your data and if they can give you information on geocoding precision. So I can't speak for every geocoder. I know the one that I use. It should give you information on what level of precision, right? Whether it's the address, street, or et cetera. You can build that into your analysis and adjust for it. You can stratify, seeing if there's a difference between the folks that geocode precisely and imprecisely when you're looking at whatever outcome of interest. I'd get that information and at least take a look at it and report it, because that's some of the issues too when you read a lot of these studies is they don't do a really good job of discussing that as a limitation. And it's huge, right? Especially if you have, like, in one of the data sets or one of the studies that I'm working on right now, 50% of our addresses are not, we don't know exactly where they are because it's older records, right? So that's a huge limitation. So yeah, thank you for that question.
Good morning, and thank you for your presentation. And perfect segue, because mine is about the addressing. So with the retention of public records, I know that things expire because with the state and county, local levels, even municipal levels, there is a retention of records limit where they don't have to keep things. But with plat books, have you looked into where they've platted the land and subdivided it and things like that? That's a requirement by federal law to do that, the survey system. So that is a way, even new developments are required by federal law to have plat books. Is that something that you've looked at for addressing? And
It has been proposed several times, in part because in these rural areas, what we're finding is that, like, say we think we're geocoding to the house and what we're geocoding to is the center of a parcel.
Oh, okay.
And the center of the parcel may not be where your house is. Ask my mom, she cannot get internet because they say she's in a holler across a creek. She's actually on a completely different road. So to do that so that may be when we start identifying areas that we can't geocode precisely, that's on the list of things to consider. But I want to be efficient and consistent, so my hope is that we can find something, like if they have electronic records or something like that, we'll try those avenues first, because there should be some data somewhere is our hope, which is trying to figure out who may have it and what level of comfort they feel in sharing it. So we're working with the Kentucky State Police now with their GIS folk. They're going to build us a geocoder because they have these little random pockets of data where they assist with dispatching. So plugging in with community members, and then they can get buy-in with this project too.
All right. She's already coming up. Good. Next presenter is Maya Leaf. Gosh, I can't believe I mispronounced your name, that I work with. She's the Associate Director of the Carolina Center for Total Worker Health and Wellbeing, and also adjunct faculty member in Gillings School Global Public Health, and all-around good egg. So she's going to be talking about designing thinking to support resilience among early childhood educators.
So first off, I just want to acknowledge the team that worked on this project. So this was a collaboration between myself, Emily Skywork, who was a design thinking fellow with Innovate Carolina, and I really want to shout out to her because she's the one who led us through this process. This was a new technique for us. And Dr. Laura Linan, who's the director for the Carolina Center for Total Worker Health and Wellbeing. And of course, thank you to our pilot project funds from NC OSHRC to do this work. So a little bit of background about early childhood educators. It's over 1.3 million workers. 40% of early childhood educators or childcare workers are racial and ethnic minorities. And they're among the lowest wage workers in the U.S., with a median hourly wage of just under $10 an hour, which comes to about $20,000 a year. There are a lot of health concerns for this worker population, a high prevalence of overweight and obesity, high blood pressure, diabetes, prediabetes, and depressive symptoms, and overall lower quality of life. And this work really emerged out of some long-standing chronic disease prevention trials that Dr. Linan was doing with colleagues at UNC. One of the things they found was that these workers in North Carolina really had a shockingly high prevalence of depression. I want to say with some depressive symptoms around 30% of the population. And so they came to recognize that mental health of this workforce was really critical. The goals for this project was to use a total worker health framework and design thinking methods to create an innovative multi-level resilience intervention for early childhood education workers and their workplace. And by resilience, we mean one's ability to maintain or regain good mental health despite exposure to everyday stressors, adversity, or change. So the methods, this was a really different type of project for us. We took a design thinking approach, and that meant that we kind of went through 2 stages. There's more than 2 stages to design thinking, but in the time that we had, we started with something called an inspiration phase. So this included a literature review and review of secondary focus group data used to develop some preliminary insights and guiding questions for our project. And then we went through an ideation phase, which was a series of focus groups and interviews that we used to prototype possible resilience interventions. A little bit about design thinking. So it's a problem-solving method. It's non-linear, so you'll see kind of as I walk you through this that we kind of went back and forth developing ideas, getting them knocked down, proposing again a different idea. Human-centered, so we interacted a lot with the childcare workers throughout this project, and iterative. And to give you kind of a sense of the overall flow, inspiration, that first phase that I mentioned, the guiding question is, what does this experience feel like? So what does it feel like to be an early childhood educator dealing with adversity and trying to build resilience? Then going into this ideation phase, what kind of solutions could we propose to meet the needs we heard about in inspiration? And then implementation, how can we make sure this works and lasts? So here is what we found. So starting with our inspiration stage. So as mentioned, we started with a literature review, looked at articles related to workplace resilience, total worker health, and early childhood education interventions. And key insight emerging from this stage was that resiliency is most successful when an intervention targets the team level. We also had some secondary analysis of focus group data, a total of 5 focus groups with 32 participants that included both directors of childcare centers as well as providers. And this was these focus groups were conducted prior to this project by colleagues doing preliminary work for another grant. And we heard from childcare workers their hesitations from all groups about the time that's required to implement and participate in evidence-based programs. So they were presenting them with evidence-based programs in the literature and saying, would this work for your center? And hearing back, no, this is not feasible. There's too much time involved, and we're already stretched very thin. And most participants in those focus groups expressed interest in workplace stress reduction programs that involved having management and staff work together, allowing teachers to have buy-in in creating and implementing solutions. From this this preliminary work, these are the key insights that we walked away with. So again, a resilience intervention needs to happen on a team level. Time to implement an intervention is the biggest barrier for these workers. The intervention needs to bring directors and providers together without assigning blame for issues in the workplace. We did hear that resilience training was of interest and it could address their health challenges, and that there was a desire for more breaks in the workday and more recognition for the work that they did. So from that, we moved into this kind of like we're getting a sense for what's going on in these workplaces. We moved into our ideation stage. And so the question that we brought forward with this how might we question phrasing, if any of you all have participated in design thinking exercises, this is kind of this thinking, brainstorming question you ask yourself, how might we design a team-based intervention that builds capacity for adversity in the ECA workplace without placing additional burden on providers or directors? And so here we start interacting a lot with the populations. We started actually with researchers who work with this worker population. 4 researchers were interviewed on Zoom for about 30 minutes each. They brainstormed solutions to that how might we question that I just shared with you all. And then they also shared their sky's the limit intervention. So all impossibilities and restrictions aside, what would you do for this worker population? Here is an example of the kind of ideas that the researchers shared with us. So you could see they just kind of had this opportunity to brainstorm different solutions for building that team-based interventions, things like teamwork across sites, having things be 5 minutes at a time, recognizing that anything extra solicits a negative response. So this is just one example of the kind of data we got from that. And then here were the sky's the limit solutions that the researchers proposed. So pay them more money, for example, would be really fantastic for increasing ECE worker resilience. But yeah, these were what they came up in response to that question. So kind of pulling that all together, the insights that we got from the researcher interviews, again, any resilience skills or training needs to be bite-sized. ECE workers feel like they do not have a network to reach out to, and the focus groups actually found that out because the focus groups connected workers and they enjoyed that experience. ECE workers want tools they can use both for themselves and for and for the children they work with. So resilience needs to be not just about them and their work, but also what the kids they're working with experience. And then any training needs to be done with intention and clear applications for the real world of these workers. So coming out of that, we picked a intervention that we thought might kind of meet some of these needs. And this intervention is called the Resources for Resilience intervention. And it has 4 components. So it involves resets, bite-sized techniques that can be used during breaks during your regular work hours, skills for emotional resilience, and these are skills that could be shared with children. It does not assign any blame, so there's no responsibility for the stressors in the workplace. And it involves training. So training is focused on trauma and one's personal anxieties and builds community across and within sites. So we then took that intervention to directors of these workplaces. We interviewed 2 directors from facilities that had different management styles and SES levels in their clientele. And the goal of these interviews was to test the feasibility of this intervention, especially the implementation of the 5-minute breaks throughout the day. And we found right off the bat that directors shared that doing these 5-minute breaks actually was really, really difficult to organize, that it requires additional staff, which costs money, which was a surprise to the team. We thought like we'd found this good solution, it's a really short break, you can do this training throughout the day. Heard from the directors that that is actually not realistic. We'll go a little bit more into that shortly. We also shared this intervention with a provider. So this provider, so the kind of the frontline worker, she completed a card sort, designing her ideal intervention from the cards displayed on the next slide. And she did not believe that anything was missing. She was asked to rank and explain her top 5 priorities for an intervention. And her main priorities were learning tools that she could individually tailor to each child, developing a community with other ECE workers, and learning tools to reset when she is overwhelmed. Actually, I'm just going to go to the summary of this level. So from sharing this intervention with the provider and the directors, these were the interview insights that we came out with, that this RFR has a potential as an intervention to change the hazards of stress for ECE providers, but those 5-minute breaks are difficult and expensive to implement. Providers still emphasize they want support of a larger community of ECE workers. However, they mentioned that it's unlikely that having an intervention like this is going to change anything in the structure of the workplace. It doesn't actually make the work less stressful. And that what they're looking for is kind of an opportunity to build community or maximize a culture of care. So that was also not very present in this intervention, and they're kind of looking for more of this connection and culture of care. So coming out of that, we went back again to a how might we question. So these are the things that we heard, you see here, that are important. Something that's team-based, something that involves resilience, something that's without burden, and something that builds capacity for adversity. So we kind of had to put aside this intervention that we thought might work, and we brought these questions back to another group of providers and directors. So here's the 4 themes again. And we then did brainstorming sessions with 3 researchers who work with this group of workers and 1 child care provider for an hour over Zoom to brainstorm about these 4 topics. So the group spent 3 minutes independently brainstorming ways to implement each of the components, and then time together talking about the themes and expanding on ideas. And here's an example of the kind of ideas that folks came up with. So around training, things like short videos, 1-minute trainings posted on social media, trainings that connect people, providing unity and connection throughout the group. Around community building, things like group chats, a break room with a reset corner, group coffee breaks. Around the concept of resets, things like breathing exercises, stretching breaks with children, quiet time, mindfulness moments. And around breaks, things like recognizing that resets might need to happen at a specific time, and that it would be important to involve the kids in the breaks, or that maybe we can have coupons for breaks, so for like achieving certain things in the workplace, be able to kind of be awarded more time for break. So just a kind of discussion of that whole process. Overall, from this iterative process of talking to providers, researchers, directors, the final conclusions that we came to is that resilience training interventions for ECE workers need to be bite-sized, again, so super short. They can't require workers to step away from their jobs. This is what I mentioned earlier. So because there's regulation on the number of providers in the room with children at any given point in time, you can't actually have a provider step away, even for a minute, even for 2 minutes, because that means you have to have another body in the room to stay in accordance with regulation. So that means you have to pay for relief staffing. So we learned, unfortunately, that that is not an option for this type of intervention. We learned that workers are interested in connection with and support from a larger community of ECE workers to combat the isolation of their day-to-day job. So we heard a lot about the fact that they're interacting with children all day long, but not necessarily with each other, and seldomly with workers in other centers, and that was like why they enjoyed participating in these focus groups. They want, again, as we mentioned, those resilience tools that can be used both for themselves and for children. And we heard that training has a negative connotation in the ECE workforce, like with many workforces. They have a lot of training that they have to do in order to be in compliance with regulations. And so if we want to have training, it has to be rebranded as something else. So for us, some proposed next steps, and this providers and directors help us come up with these proposed next steps. They were interested to know what resilience interventions might already exist by a different name. So different types of health interventions are already taking place in these workplaces, and they thought that we should kind of do a inventory to see which of those might be relevant to resilience. They suggested that we host sessions with ECE providers and directors to get deeper on this concept of community and what community might look like for the center. That we build partnerships with ECE directors to keep institutionalization of the intervention at the center of the design. That we begin to refer to breaks as resets, but we still have to figure out how that could actually look feasibly in the workplace. And that we begin to refer to training as something else, perhaps resilience community building, to get away from that negative connotation with the word training. So acknowledgements, again, I really want to acknowledge Emily Skywork, who really led us through this work. It's a new technique for us. Carolyn Sear, who her team provided some of that original focus group data. And of course, our funder for this project.
So I'm also fascinated by this concept of resilience, and I feel like over the course of COVID that it was kind of pushed against as being this individualist trait that we need, and so looking more at the ecology of resilience. So I was wondering if you explored kind of outside of the workplace what these, and in most cases it's women, what they are going through, the ecology of what makes them feel resilient that might exist outside of the workplace that the workplace can help support or build upon in the interventions.
Yeah, that's a really good point, and I'm thinking back, and I don't think that came up as much in the discussions that we had, just because of the nature of the way we frame the questions. I do, as you saw, like we did grapple with like the workplace itself as a stressor, right? Not just building like these trainings to help, manage your resilience in what's going on, and that what we just kind of kept hitting up against like these staff ratios and just like the low wages and things like that. But that is a good question. That could be something for future work to look at the wider community. Thank you.
My question on this was, I know you said this was a fairly new technique for you and Laura, guidance from Emily, but of potential adaptability of this for, I'm thinking of bias, my wife is a teacher, but also future studies like the rural physicians and nurses, but like dealing with the ER nurses and taking this type of approach. We heard earlier.
I think it was really interesting to observe the interactions between the researchers who'd been in this field for quite some time, like many years, like had just wrapped up like a 5-year controlled trial working. So like knew this population well, but then when we got folks in the room together to talk about what an intervention could look like, it was just like instantly like, that's not gonna work. Like it's in the literature and like, yeah, we see why you wanna test it, but it's just like not realistic for us. And I think it was a disorienting kind of experience to be like, okay, we have an idea. We have a meeting tomorrow. Oh, that idea is not going to work. Okay, now we have to come up with something else for another meeting. But I think it was valuable, especially just to see even like veterans in the field learning quickly, like what was, what the limitations were. And I mean, it was interesting in the sense that like the meetings were happening like, in real time, like analysis, scheduling a meeting for the next week, analysis, scheduling a meeting for the next week. So the process felt a lot less structured than what I'm used to from like other qualitative work that we've done. But it was really valuable to hear from them, like in real time, so.
And what was it? I saw a reference on one of the sticky note pictures. What was meant by the secret trainings?
I don't recall.
I'm just wondering, was that like secret rules of thumb or, heuristics or something that they pass on?
Yeah, no, I don't recall.
Okay.
Our first presenter in this second session this morning is Dr. Alex Albert, and he is faculty at right here at NC, and he'll be talking about improving hazard recognition in the construction sectors.
Good morning, everyone. It's an honor to be here today and share some of the research that we've been doing with some support from North Carolina Occupational Safety and Health Education and Research Center. We've worked on quite some research looking at construction hazard recognition and construction safety in general. And I'm excited to share some of this research. I've just acknowledged two of my students who have now gone to other institutes to begin their own research careers. So we've examined construction hazard recognition as a visual search task in an effort to understand why hazards remain unrecognized and how we can improve hazard recognition. And I'll talk a little bit about what I mean visual search, what I mean by we examine construction hazard recognition as a visual search task. So just some background why focus on construction safety. We have about 60,000 fatal incidents every year. This is globally. From the construction industry. That translates to roughly about 6 fatal incidents every 10 minutes. So that is a huge number of safety incidents. And just within this session, we can expect quite a few number of workers to lose their lives, right? And these are fatal incidents. We obviously have more common injury types such as lost work time, medical case incidents, and other incidents that are not captured as part of fatal incidents. Looking at the United States, we have more than 900 fatal incidents and over 200,000 non-fatal incidents reported from the construction industry every single year. There are many reasons for why we have this large number of incidents in the construction industry, but one of the reasons is poor hazard recognition levels. So if workers are unable to recognize safety issues that can pose harm, then the likelihood of incidents are quite high. So if you look at research across the globe, you can see from the United States there's consistent research that construction workers fail to recognize between 40 and 50% of safety hazards that they are exposed to in the workplace. Likewise, from Australia, there's evidence that some workers fail to recognize up to 57% of safety hazards. And we have similar evidence from the United Kingdom and other regions around the globe as well. So looking at the importance of hazard recognition, so towards the left side, if you see, you have the hazard. So if a hazard is present, and towards the bottom, you have not recognized. So if the hazard is not recognized, it's just unlikely that the construction workforce is going to come up with safety controls that can prevent these incidents from happening, right? So if hazards remain unrecognized, the likelihood of safety controls to be in place is going to be less, and the likelihood of incidents are going to be much higher. If you look at the top, you can see if the hazards are recognized, workers are able to evaluate the safety risk posed by these hazards. They are able to come up with safety controls, and then you can prevent incidents. So really, whether hazards are recognized or not can make the difference between whether you have a fatal incident or not. So we wanted to understand why construction workers fail to recognize safety issues. There's a lot of research looking at risk management, risk assessment, and so on. But this is more of a fundamental question: why workers are not recognizing safety issues in the workplace, and only if hazards are recognized is any risk evaluation even useful, really, right? So we decided to examine construction hazard recognition as a visual search task. So similar to if you're looking for a product in a grocery store, or if we have baggage screening at an airport terminal, or if a radiologist is looking at a radiograph to see tissue abnormalities, we wanted to examine construction hazard recognition in the same way. And the way we kind of did that is we used eye tracking devices. So essentially, these devices capture the movement of your pupils, and it can give us information on exactly what you're looking at during hazard recognition operations. So we did this study based on a computer-based study, but then we are expanding it to examine visual search patterns in construction workplaces. So we started off with a very simple study. We recruited a bunch of construction workers. We asked them to recognize safety hazards, and we used construction case images that were captured from real construction projects across the United States. For each of these images, we had a list of safety hazards that were present, and these hazards were identified by a panel of 17 industry experts with extensive experience. So for each case image, we had a list of safety issues that we would have liked the workers to identify. Right? And we just identified some of these patterns. So these are what we call attention maps or heat maps. You can see that in this case, this particular worker who was examining this work situation was particularly focusing on the primary task, but then there are hazards all over the workplace which largely remained unattended to, right? So in other words, the visual attention was not devoted to several other hazards. And so we saw that workers were often able to identify hazards associated with the primary task or the central thing that's going on, but there's several other hazards in the work environment that often remained unrecognized. Here's just a pattern of search, so search patterns. So you can see towards the left, this particular worker examined few areas. On the right, that worker examined a much higher area, so it's just the attention is distributed much broadly. And we saw that there was about 50% difference in the hazard recognition performance when you look at the ratio between hazards that were recognized versus the ones that were present. So why do construction hazards remain unrecognized? We found a bunch of factors. We just spoke about selective attention. So selective attention is when you're devoting much of your attention to maybe where people are located or maybe the primary task, but not paying attention to other safety issues that are in the area. We noticed premature termination of the hazard recognition. So we noticed that construction workers during hazard recognition operations, they identify 4 or 5 hazards. So they just say, likelihood for trip, likelihood for fall, likelihood for pinch points, and then maybe after 3 or 4, they actually just randomly stop. They feel like the work is done. So we saw that was an issue. We saw that some workers did not report hazards that they perceived to impose low levels of safety risk, although the expert panel that were consulted thought that they were important hazards. We saw multiple hazards associated with a single source. So for example, if you have an electrical cable on the ground, sometimes the workers reported the electrical part of the hazard, so the potential for electric shock or something. But on the other hand, they did not report the trip potential that it poses, right? So the same source may be associated with different outcomes. And there's a bunch of factors. I'm not going to go through all of them. My students have and as we've reported this in a research article, which you all could probably look at. So some of the implications, we examined what were challenges associated with hazard recognition with a very simple study with using eye tracking technology. We think this has training implications. We know why workers fail to recognize hazards from a study at this point, which is fundamental knowledge. And now we think we can improve safety training, we can improve tools that support hazard recognition in the workplace, and so on, right? So that's our study one. So then what we wanted to do is we wanted to see whether how workers examine the workplace, if that is predictive of hazard recognition performance. Okay, so we just wanted to see how they examine the workplace. Is that going to give us information on hazard recognition performance? And we wanted to see if we can train workers for hazard recognition. So essentially, would training change the way that they examine the workplace, and whether that change in the way they examine the workplace is going to translate to superior hazard recognition performance. So we just looked at the literature. We found a bunch of metrics that is commonly used in similar studies. So we looked at maybe for example, search duration. Search duration is how long or how much time are workers taking to examine the workplace. This is linked with, if you remember, we spoke about premature termination of hazard recognition. So workers terminate their hazard recognition effort after identifying or reporting a few hazards. So we wanted to capture metrics associated with that. So that's search duration. We had fixation counts. So fixation counts are when the workers stop the pupil movement and focus on a particular stimuli or an area in the case image in this situation. Fixation time is the amount of time they spend looking at a particular stimuli of interest. We have fixation spatial density, which is just the distribution of attention across the work area. So for example, what we did here is we just came up with a grid system, and we said if workers pay attention to a much larger number of grid areas within the grid, then they have much higher spatial density, right? So if they've allocated attention to different areas in the grid, then they've allocated their attention to different areas. So there's a bunch of metrics. I'm just going to go through a few, but then what we kind of did is we recruited workers focusing on different trades. We did a very similar study. We presented these hazard recognition case images. We asked them to identify safety issues. We took a random sample of 6 construction case images from a pool of 16 that we thought were representative of different construction operations. And then we were able to quantify the number of hazards that were identified. So really the number of hazards they report verbally. So that's the numerator. The denominator is the total number of hazards that the expert panel pre-identified before we started our research study. So for example, in this case, if a particular worker identifies the 4 hazards that are highlighted in green, then their hazard recognition performance is 50%. In other words, they've identified 50% of the hazards in the work in the case image. So looking at whether visual search patterns were predictive of hazard recognition, so we saw that search duration, so how much time a worker allocates to hazard recognition, does impact hazard recognition performance positively. So the more longer time a particular worker examines the work environment, we are not advocating for too much of time, but just in the amount of time, just across the sample, we just saw that workers who take more time to examine the workplace for safety issues identify more safety hazards. Likewise, fixation count was positively linked with hazard recognition performance. Fixation count, that was as fixation time, and a few other metrics. So how well they distributed their attention was also predictive of hazard recognition performance. And then what we did is we said we wanted to see if we can introduce training and whether that training is going to impact visual search patterns or how they examine the work environment, and whether that's going to translate to superior hazard recognition performance. So again, we took the baseline. So before we introduced an intervention, we took the baseline information for how they identified hazards before an intervention was introduced. As the first measure, similar to what I just talked about earlier, we introduced an intervention, and then we tested them again after the intervention was introduced. In terms of the intervention, we just used the intervention that we kind of developed in a previous study. So the intervention is described in this particular article. But just to summarize, what we did is we've incorporated quite a few elements into the intervention. So first is visual cues. So visual cues What we've noticed from our studies is that construction workers don't have a systematic approach for examining the workplace for construction hazards. They often just look to the right and they say there's a trip hazard, they look to the left, there's a fall hazard, pinch point hazard somewhere. So they don't have a systematic approach, it's more random. So what we said is maybe we want to try and give them a systematic approach for recognizing hazards. So for example, gravity, we gave them pocket-sized cards. So essentially they could use this pocket-sized cards. They could look at, okay, the first energy source here is gravity. Are there any gravity issues, right? So fall potential, trip potential, and so on. Likewise, motion, right? So is there a heavy equipment that we should be aware of? So systematically going through these energy sources one at a time, we have 10 energy sources here, we thought could improve hazard recognition levels. So that was one part of the intervention. The second part of the intervention is we just gave them feedback on hazards that they identified versus hazards they did not identify to just kind of give them an idea of what is expected from hazard recognition itself. So just positive feedback on things that they successfully recognized and feedback on things that they could have recognized as well. We also used attention maps in this feedback process. So essentially you can see this particular worker who examined the workplace focused on specific areas where that particular worker was working. So, and we gave feedback in 3 categories. We said you've successfully recognized a few hazards, so you've allocated attention to certain areas and you've successfully recognized those hazards, great. You have detection errors, which is you focused your attention in that area, but you just do not report it as a hazard. And then we have search errors, which is you've not even devoted attention to that particular hazard, and so you fail to report it as a hazard. So that was kind of some of the feedback. And then we gave them metacognitive prompts. So essentially, we looked at the hazards that remained unrecognized from the baseline phase, and we asked workers to examine if these factors were relevant. Did they selectively attend to certain areas and not to other areas, and kind of come up with remedial interventions themselves to improve hazard recognition levels in subsequent hazard recognition phases. And that we used a template to kind of give that information to workers. So overall, we saw that training did impact the way workers examine the workplace, and that resulted in superior hazard recognition performance. And training also resulted in superior hazard recognition independent of visual search changes in visual search patterns. So there were two-way improvements, and it was not just because of the way that they examined the workplace that hazard recognition performance improved, but also visual search patterns changed, and that resulted in improved hazard recognition performance. So some of the implications, we are trying to develop methods to evaluate workers prior to them entering into the workforce, so maybe give them some, evaluate their training needs. We're trying to predict hazard recognition performance. We're trying to see how can we predict hazard recognition performance and give remedial training. We think we can use some of our methods to assess how training interventions, how effective they are. And then we think we are trying to address some of the human factors associated with hazard recognition, right? So it's just not the lack of knowledge that results in poor hazard recognition performance. It's also just human behavior and human factors. So with that, I'm going to say thank you. Any questions?
Dr. Albert actually is from North Carolina State University, and I don't think I accurately represented that. How many people were listening to this talk and thought to yourselves, this approach has applicability for me in my studies? I thought about that for some of your work with nurses and walking into a room taking charge. I think about that working on commercial fishing vessels, knowing that most of the gear is not inspected before you go out on each trip. Mm-hmm. When I rent a vehicle, how many of you rent vehicles? How many of you walk around the vehicle unless they make you do it, and you look at the tires, make sure every light is working? So my question is, how much do you think the operation of capturing pupil movement data serves as an intervention by itself, and how difficult is it to collect those kind of data? Like if I wanted to collect pupillary movement data from this population here, how hard is it to apply that, get it done, and collect meaningful data?
So Sounds great. Great questions. First, just a little bit stepping back on the inspiration for this research. The inspiration for this research really came out of marketing. We saw that, for example, Target and Lowe's, for example, what they were trying to do is they were trying to send customers into their stores, and they were interested in what are customers paying attention to. Are they paying attention to the price tag, or are they paying attention to the product ingredients and things like that? So the inspiration for this research was really based on some of this previous research in marketing, which we thought was useful. So in terms of the question about how easy it is to capture eye tracking data, as part of this study, what we did is we used remote eye trackers, which are just placed in front of your computer, and it captures your eye movement, right? So we didn't, at least the research that I shared here today, we didn't go to the real workplace, right? And so this research, this data is quite easy to capture, and increasingly even webcams are able to kind of track some of this data, but we are still not there yet. We have dedicated eye tracking devices which do the job much better. And we have software that does it very easily, really. And in terms of the real world, if you look up Tobii glasses, for example, online, you can see they're just like glasses. So when Target is sending customers into their stores, they just wear something like a glasses. It has a battery package. So it's just a cable attached to a battery cable. I should have bought that with me today. That would be cool. But essentially, it's just like glasses and a battery package attached to the glasses. And the software captures the data quite well. And increasingly, there's interest in integrating more wearable devices for your research. For example, we are trying to integrate EEG and eye tracking and GSR, right? All of that into. So you can expand on what we've done, and there are tools now that actually helps you integrate all of these individual data sources. Should be quite straightforward. There are open source software packages, like for example, Ogama is one that's an open source software package. Tobii, with their products, they have their own software packages that make it really easy. You don't need a computer science background to collect this data. Yeah. Yep.
Real quick, this question's inspired by Mr. Collins over there. He wanted to know basically if just because the eye tracking software identified that they were focused in on an area, does that mean that they actually recognize the hazard, though?
No. I'm just going to go back here for a minute. Great question. So what I said here, if you remember, I said, yeah, some cases they are devoting attention to the hazards and they're successfully recognizing it. Some other cases, they devote attention to the hazard, but they do not report it as a hazard. We call that detection error. And in some cases, they examine the workplace, they just don't devote attention to the hazard, and so they don't report it as a hazard either. Yeah. Great question.
Was there a way that you could kind of account for random eye movements? Because I know a lot of people, they'll just scan the room without actually focusing in on something. They'll just look over here just because they're anxious or something. Was there a way that you could account for that?
That's a great question. We should think about it a lot more. Yeah, I think, as part of our efforts, we tried to not introduce anxiety among our workers. Overall, we just tried to, we did give some instructions on not having your cell phone, and things like that. But yeah, I think that's something we got to look at. And we were looking at the patterns on average, right? So on average, that's what we found, right? So there could be, eye movements that are not related to the hazard recognition operation itself. Yes. We've also done studies with distraction, right? So place some distraction in the workplace and whether that's distracting them from the stimuli of interest. Yeah.
So kind of in line with that question, I don't know the prevalence of these issues in the general population, but things like strabismus issues, the eye muscle issues, did you guys ask them if they had any eye issues prior to coming in? Because with construction work, right, like that's a hazard of their occupation.
Mm-hmm. Yeah, so there were some criteria that we were looking for, which the IRB also asked us to kind of evaluate and maybe make sure people don't have a health condition before they are enrolled. That particular health issue, I don't think we came across. We just sampled a few workers, so we didn't come across that particular issue.
That could cause the eye to not be able to focus, right? Because like one eye will look at you and one eye could drag.
I guess, this tool probably may not work as well in that situation, I think. Yeah, we just didn't encounter that situation because we used a very small population. But yeah, I guess we got to.
Well, and it can be corrected too, right? Like there's prisms and things that they can do to help the eye muscle compensate.
Yeah, there's some calibration from this eye tracking technology. So you got to calibrate this device first, so it makes sure that it works initially. So that's a good question. I've not seen if you can calibrate it for that issue, but probably you can. Yeah. Mm-hmm.
Thank you.
Thank you.
So my name is Michael DiStasso. Just to give a little bit more clarity about what I mean about concerns about change, concerns about return to work specifically. So changes that happen in the workplace while people were absent. And so just to give a little bit of background about myself, I'm a PhD candidate in the IO psychology program at UCF. I kind of brand myself as an occupational health psychologist too. And a lot of my work is related to cognitive psychology. And I also do a lot of research in the hospitality management area. So I have a little bit of an identity crisis. So you see that throughout the presentation where I have a lot of integration of different areas. The other thing I'll say is I'm really thankful to be here. I mean, all of these presentations have been really cool. So I'm going to give you guys a little bit of hospitality management to sort of complement everything that we've learned about jockeys and early childhood educators. And then just one more thing before I jump in. This is part of study one of my dissertation. So I'm really excited about this work. And if you want to talk about it afterwards, I would be happy to do that. This is an overview of what I'll be talking about. I'm going to give you the highlight of the concerns about change studies, especially in terms of the results. If there's anything that you really want to talk about afterwards, if there's like, oh, I wish he had mentioned something about this, like I'm happy to talk about it. I'm really excited about this work. So jumping in. So COVID-19, I mean, had a major impact across the globe, across industries. It's not just hospitality, but if you think about hospitality management, and specifically in sectors like hotel lodging, food service industries like restaurants, theme parks. So, I'm in Orlando, so theme parks, unprecedented and really catastrophic is probably the best word to use in terms of the impact. I think an estimate that I saw was 2/3 of restaurant workers were laid off at the onset of the pandemic. So really unprecedented. And our study focuses on the experiences of workers that have been laid off or furloughed. So I'm not as interested in the people that stayed at work and were working through the pandemic. I'm more interested in the people that were furloughed. And these people were in awkward, precarious situations. So they got really bad news. Your job is being retired either temporarily or permanently. And there are a lot of changes taking place outside of work, of course, during the pandemic, and then during, inside of work as well. So the workplaces themselves are changing while they're kind of on the outside looking in. And when I say looking in, like people have different information sources. So there's former coworkers. So think like, okay, you could informally chat with like, oh, what's been going on at work while I've not been there? You could have like informal communication from your managers. And then the news. So for example, one of the theme park workers I was talking to last, I guess, December 2020, she said that she actually found out that she was laid off from the news first rather than from her management. And she was like, oh, that's how I found out. So news actually for a lot of people in the theme parks, that's where they got a lot of their information. And I'm going to talk about return to work worries specifically. So when I said I'm really interested in cognitive psychology, this is what I meant. So I'm really interested in people's thoughts about the future. So their expectations of what will happen, sort of imagining what could happen, and then, of course, their worries about what could happen as well. So worries are future-directed, more prevalent when we have incomplete information. So when there's ambiguous situations, we're more likely to worry. And In the work context, I'm sort of proposing here that workers could worry about what could happen at work. So all of these changes taking place that I mentioned, even when they haven't returned yet. So like I said, they're on the outside looking in, and there are all these changes. Well, I don't have complete information about what's happening. I don't know if my job is going to look even similar to what it was before I was laid off for load. The one thing I will say in terms of all the different fields of expertise I have, none of it is clinical psychology. So in terms of anxiety disorder, no, that's not what I do. And so I'm not as interested in the generalized worry, worry in general or anxiety, more about specific things. And so the reason for that is I want to get targeted towards what are the specific aspects of the changes in the work environment that people are worried about, and see how that predicts their well-being. And in terms of choosing worries, you guys have seen this as early as yesterday. Dr. Tamers talked a lot about the priority areas. And so when we're going in and selecting different domains of worry, what might people be worried about? We drew from some qualitative a prior study from earlier last December. And then we just sort of talked as a group, like what might people be worried about in terms of, okay, COVID-19, what changes have been taking place? So we drew from this framework, and we tried to capture as much of the framework as possible, and specifically focusing on aspects of the work environment that might have been impacted by COVID-19. So return to work worries, I'll talk about some of them. In a later slide, I'm going to have a full list of all the different domains that we ended up selecting. So when we think about what workplaces might look like, there are a lot of issues that hospitality workers could be worried about. They could worry about stressors like COVID-19 exposure or the possibility of being exposed to COVID-19 while working, workload levels. So that would be workers who worry about how difficult their work is or how much work they're going to have when they return. Mistreatment comes up a lot in hospitality work. They could also be worried about different job conditions. So we focused on sick leave. When I'm back at work, and if I get sick, like how flexible is my employer going to be with me? And then work scheduling policies as well. So how flexible is my work arrangement? And these are our research questions. So the first one is more of a prevalence kind of question, so I was interested in what are the major worries reported in hospitality workers. And the second one and third one, so the second one is kind of focused on an issue that's been coming up in hospitality about a year after the pandemic. So hospitality has been having issues with retention, and it's now sort of seen as an industry that it's having a hard time retaining workers. A lot of people didn't decide to come back. So I was really interested in the concept of returning intention. So the idea that maybe I'll return to the same company, so the organization return intention, maybe or maybe not, I'll decide to return to the same industry. So I'm okay with being in hospitality, but maybe I'll find a different sector to be in. And then research question 3 is concerned with well-being. So mental health, physical health, life satisfaction, and sleep quality we looked at. In terms of our process, we partnered with the Rosen College of Hospitality Management, and they were able to get us on some listservs, so we were able to get this survey out that way. And we focused on lodging, food service, and tourism and theme parks. So our sample ended up being largely restaurant workers, so food service, but that was about 60%. A fair number of the other ones that I mentioned were represented. To be eligible for the study, a participant had to be currently laid off or furloughed from their company, and furloughed or laid off due to COVID-19 specifically, so not laid off for any other reason. And we recruited both online and through the listservs that I mentioned in early, spring last year. So we have some demographic information. So the survey, in terms of how it was set up, was pretty interesting. So it had several different sections where we first asked them, okay, here's the domain this section of the survey is about. Like, what are your concerns pertaining to this domain? And what do you think the workplace will be like in terms of potential changes that might have happened in this domain? So for the workload section, they got to say, okay, I think the work will be similar, but maybe there will be more of it, or I think we'll be understaffed, so I'm going to have higher workload. So in terms of data analysis, just to preview what's coming in a couple slides, I'm going to show you guys some descriptive information to sort of get at, okay, what are the highest levels of worry? So going back to that research question 1, stepwise regression for looking at the return intention, so taking out the predictors that are most, or the predictors and the worries that are most associated with intention to return to your original company and your intention to return to the industry. And then relative weights, so regression with relative weights analysis to look at some of the worries that best predict some of the well-being indicators that I mentioned. Now, I'll go over some of these. So these are the domains that we landed on, sort of, as I mentioned, like talking about the total worker health priority areas, talking with our prior data set. So worry about COVID-19 exposure, so that's worry about being exposed to COVID-19 on the job, chemical, biological exposure as well. Worry about org constraints, so how difficult it is, like, so barriers in terms of like red tape, maybe management doesn't let you do the things that you want to do. Worry about mistreatment is a big one for hospitality management. We looked at the possibility of being mistreated by guests, which is probably the bigger issue in hospitality management, but also being mistreated by coworkers. Workload intensification is sort of the idea that maybe my workload will be unbearable when I return to work. The worry about following and enforcing COVID-19 safety policies, so things like mask wearing, so a lot of frontline workers were sort of burdened with the idea that they should be enforcing the guests and the customers to be wearing their masks versus the following, which is me. Following my own safety procedures. Sick leave flexibility and work scheduling flexibility I mentioned before. And then the last one was vaccination. So we asked people, to what extent are you concerned about the vaccination of your peers and then of guests? So that's all of the domains of worry. We measured each of these with 3 items from like a worry scale and then tailored them. I won't show you guys the tables with the full descriptives, but you can come talk to me afterwards if you want to see it. These are the top 3. So worry about COVID-19 exposure was the top one. Worry about mistreatment from guests was the second one. And worry about enforcing COVID-19 safety policies was the last. So in terms of research question 2, so the sort of contrast between industry and organization return intention. So when it comes to the organization, people were less likely to report wanting to return to the company if they were worried about sick leave policies and if they were worried about workload levels. On the industry side, it was worry about enforcing COVID-19 safety procedures that made them less likely to want to return to the industry. And so we have regression results for organization return intent. Again, the 2 significant predictors are worry about sick leave policies and worry about workload intensification. And then for research question 2, the table for industry return intention. So only one type of worry was statistically significant here, and it was worry about enforcing COVID-19 safety policies. In terms of research question 3, so here are some results pertaining to the well-being indicators. For the well-being indicators, mistreatment was the biggest one. To some extent, the mistreatment from coworkers and customers, but guest mistreatment was largely the concern that most people had and was most related to these well-being indicators. So for mental health, physical health, guest mistreatment, coworker mistreatment came up. And then for life satisfaction and sleep quality, guest mistreatment and coworker mistreatment also came up, and they had pretty high relative weight compared to the other worries that we had in our model. So in terms of implications, so line level hospitality workers had different levels of worry for different domains. That's kind of the reason we separated out the different types of worry in the first place, is because we knew like this general worry wasn't good enough. We wanted to get more specific. And so when we look at the descriptives, greatest for issues pertaining to COVID-19 exposure, and greatest for issues like dealing with customers as well. And then, as we can see in the results, different worries were associated with intention to return to this original company versus intention to return to the original industry. When it comes to the industry, people were more likely to factor in enforcement of COVID-19 safety policies, so people saw that as an industry-level issue, whereas for organization, they were more concerned about workload levels. In terms of practice, so I think the thing for recommendations for hotels and restaurants, they need to be addressing concerns about workload levels and sick leave policies. So this can be in the form of communication, so via newsletters, via one-on-one conversations. So if they're trying to attract workers back into their setting, then they need to be talking about these issues and talking about how they can alleviate them. So either resources that they provide to help employees manage their workload levels, for example. For the industry broadly, the recommendation is to address concerns related to the enforcement of COVID-19 safety policies. So it's now been a year, and to some extent, the policies have become somewhat more ambiguous as Omicron is dying down, but we'll see what things look like soon. But this is a concern of the frontline workers, and so I think the idea that having to enforce policies is seen as a stressor for them. On the theory side of things, this applies psychological theory of future-oriented thinking, my favorite thing, to workers that have been laid off or furloughed. So the idea here is people think about what their job could be like, even if they're not already in the job, and they don't really know how the job has changed, but they're thinking about it. And so they have these expectations about what things will be like when they do return. And I just have one more slide for the acknowledgement. So I have my two undergraduate research assistants. My proteges are Angela and Iggy. And then Wheeler was also my coworker and my advisor, Mindy Schoss. And I'm really thankful to the Sunshine ERC and the PPRT for funding this work. So thank you so much, everybody.
The mistreatment from guests, do you think that was a new worry? Like, do you think it was present before COVID? And if not, why do you think it's changed with after COVID? Why are they now worried about it?
Yeah, I don't. So it definitely existed before COVID. And so guest interactions has been like a field of study long before COVID-19, but I think it's been intensified. So, I mean, you hear news stories about negative interactions with customers that have been sort of, over mask wearing, over enforcing different kinds of policies. So I think more so now than before, but it was still a concern before.
Good morning. Thank you for your presentation. I wanted to start out saying I'm glad that UCF's here. It is my alma mater, and Orlando is my hometown, so I'm glad that you guys are here. So a couple of questions.
Sure.
We really didn't mention any of the business types. So a lot of them you were saying were the restaurants and things like that, and you mentioned the Rosen Hotel, Rosen Hotel system, or Rosen School of Hospitality rather. Did you look at like the ancillary uses for Walt Disney Corporation?
Oh.
So that's something that you have the upper management versus the lower management versus just your cast members. So did you see potentially, or did you look at a variation in maybe psychological stressors based off of that?
Yeah, so what we collected here are frontline hospitality workers, and specifically they had to be interacting daily with guests and customers. So we didn't look at the concerns for managers. If that is that sort of what you're thinking?
Yeah. Okay. Also, like external factors too.
Yeah.
Like for instance, I know from being from Orlando that a lot of these service workers move to Orlando just to be service workers, and they share houses together and things like that. So their socioeconomic status may play a factor into this as well. So I'm wondering if that's something that you potentially looked at or.
Not in this study, but it is something that we've definitely been thinking about and looking at. Because I think the lower SES kind of folks that come into Orlando for this work, they're more vulnerable. But we focus on the factors inside the workplace specifically, but I totally agree with you.
Oh, thank you.
Yeah.
Our final speaker this morning is Avian White from East Carolina University. And we're going back to the world of equine practice, and she'll be presenting part of her dissertation work. It's not your dissertation work, but your aside. So here's an example. You're still a candidate, right?
Yeah.
So here's a doctoral candidate moving forward, advancing her degree program. And like many of us, we have a lot of side projects that are equally as important, but still need to be accomplished in the same time zone. Avian's talk is entitled Horse Owner Practices and Equine and Human Arboviral Encephalitis in North Carolina. So this is really, I think, representing our real zoonotic potential contribution to this meeting. So bring us home on that, and let's bring humans and horses and industry together.
Good morning. So thanks for having me. And like you were saying, this is kind of something I did aside from my dissertation. So my dissertation is actually looking at wastewater as surveillance for COVID. So it's so different. But I've done a lot with mosquitoes. I love mosquitoes. This seems weird to say, but they're like home to me. You know, who loves mosquitoes? But and so I just want to talk to you this morning a little bit about mosquitoes and how they affect humans and horses here. And we did a study here in North Carolina. And so just a little bit of background. And so I am a doctoral candidate. I'm a walker when I talk. And so I'm a doctoral candidate in public health. And so what we're really kind of looking at is here, how do we merge environmental health and public health to actually kind of mitigate exposure to some of these diseases and make people aware that these things are out here. And so this concept of One Health actually talks about that kind of circle of life, you know, in Orlando and Disney, so let's take it back to The Lion King, you know. And so the circle of life between people and animals in our environment, how they all interconnect. And so when you think about that, we think about mosquito-borne pathogens, you know, these things, and, you know, they're the biggest causes of human health and disease worldwide. So I teach a vectors class at ECU, and one of my big first questions is, you know, what animal kills the most people? And so I hear sharks, lions, bears, and I'm like, no, dude, it's mosquitoes. You know, and thinking about mosquito diseases, and a lot of diseases that are out there, here with our students, you know, it's not something that's at the forefront of their minds, because when they think about mosquito-borne diseases, they think about tropical nations. And so they think about continents and countries in Africa, and they may think about India, but they don't think about Eastern North Carolina or even the United States and how these pathogens affect us. And so two of the biggest pathogens that we wanted to focus on and talk about were West Nile virus. And so there's West Nile fever and West Nile neuroinvasive disease. And then we also wanted to look at Eastern equine encephalitis, which is caused by Eastern equine virus. And so these two diseases actually do cause significant mortality and morbidity in humans and in horses. And for horses or equines, they are preventable by vaccines. And I feel when I'm doing this now in the world of COVID, vaccines kind of seem like a dirty word, but it's really to help our equines because they're really, really bad for them. And so just kind of looking at the first one, West Nile virus, really, when you think about it in the big scheme of things, it's kind of recent because it didn't emerge into the United States until 1995, and so it was in New York City, of all places. And so the primary species is what we call our common house mosquito. It's a Culex species mosquito. And so these mosquitoes are all around throughout the United States. And it's actually maintained, the virus is maintained in nature through a bird mosquito cycle. And so what happens is when we get bit by the mosquito, we can get sick, but we don't generate enough of the virus. So if a mosquito bites us, it can transmit it to another person. It's when it bites a bird that the bird has enough of that viral pathogen that it can transmit. And so we say that's how it's maintained in nature. And so some of the illnesses that West Nile virus can cause are West Nile fever. And so with that, you get sick, you know, you get a cough. It's kind of like having the flu a little bit. And then there's the more severe West Nile neuroinvasive disease. And so this inflammation of the brain, and we see this is particularly deadly in older people and younger people. And so what we have kind of the trends that we see here are in the fall, we see kind of an upward tick in human, late summer, early fall human and equine cases. And so one of the things we think is that the primary bird species for some of these mosquitoes kind of migrate south. And so they're like, well, I need someone to bite, and they bite humans. And so the second one that we looked at is Eastern equine encephalitis, or triple E, as you may have heard it called. And so that one we found it a little bit earlier in 1931 in the United States. And this, again, is maintained in a mosquito-bird transmission cycle. And so what's kind of weird about this one is the primary vector is what we call the Culex melanura mosquito. And so this mosquito actually does not like biting humans. It just loves birds. And it'll go to other amphibians. And so we actually do mosquito trapping in Brunswick County. And so one of the guys said, hey, we could bring you some snakes and you can test those snakes. I'm like, no, that's okay. But it transmits it. It'll bite birds and frogs and things of that nature. And then we have these things called bridge vectors. And so these bridge vectors are the ones that actually will bite a frog or a bird or something else and transmit it to us. And so the bridge vectors are Cochleatidia species, and so you may have heard of Cochleatidia perturbans, or Aedes species, and those are endemic throughout. So Aedes albopictus, which are the Asian tiger mosquito, which is just all around now. And as it's getting warmer, that's that little black mosquito that you're swatting around your ankles all the time. And then again, look who's back, that Culex species mosquito. And so the triple E, or Eastern equine encephalitis, does cause neuroinvasive disease in humans and equines. And so what we see with this one, especially in equines, is it has an 80 to 90% mortality rate. So it is particularly deadly. In humans, we see long-term health, again, because of that neuroinvasive disease. And so what we wanted to do here is we wanted to see is if there was, and we just looked at North Carolina particularly for this, is there any kind of correlation in time between seeing triple E in horses and triple E or West Nile neuroinvasive disease in humans? And so that's what we're looking at here. And then because we do want to, because we know it's really deadly to horses and we know it's really, really serious, we wanted to look at our horse farmers or our equine farmers and find out what knowledge do you have? What are some of your concerns about this? Do you have any concerns? And so those were our two main objectives here. And so how we accomplished that is we had an IRB, and so we kind of got data from DHHS, North Carolina Department of Human Health Services. And then we also did some outside systems too. We had to get a data use agreement for electronic disease surveillance system. We did, I don't know if you've heard of the CBC, ArboNet, we use them, that's a public system. And we did a little kind of side work there just to see, is there a difference with the public system? And that's what you can kind of go online and see versus what we get from the private system. And so we did look at that data too. And then the second part was a survey that we sent out to our horse farmers. We sent it out to about 500 horse farmers. And so we gave them a $10 gift card to kind of, hey, answer this and participate in that. And so with the survey, we did, USPS, mail, Facebook, email. Those were kind of the mediums that we used for them to do that survey or kind of send it back into us. So kind of some of the things that we found here was the distribution of triple E. As you can see, it's all throughout throughout North Carolina. So triple E and West Nile virus. If North Carolina, if you go back to kindergarten or first grade social studies, had the Piedmont, the mountain and coastal plains, we see these viruses all throughout. And in some places, they're seeing double. So some counties have actually reported cases of both triple E and West Nile virus, which is particularly concerning. And so for our purposes, we kind of looked between 2008 and 2018, and this is what we found here. And so then we kind of wanted to show you a breakdown with humans and horses, and we looked at that. And so what we saw were, for West Nile virus in humans, we averaged about 3.6 cases per year. And so that's pretty high when you think about it. Horses, a little lower, is about 1.3 cases. But we flip that when we do triple E or Eastern equine encephalitis. And so humans, maybe about 1. You round it up roughly to about 1. But look at horses. 9 cases, you can round that up to 10, 9.6 cases a year. That's a huge increase in triple E virus. And that kind of lets us know that there's something going on with these mosquitoes that's out there, and we need to figure this out. And so we did do some correlation here between human and Eastern equine encephalitis, and we did see that where there was 1 human case, there were at least 3 horse cases of triple E throughout those years. The only time that we saw that there was an exception was 2016, which was really weird there. But that was concerning to us, and it said that, we do need to be watching our horses, and maybe they can tell us what's going to happen for us. And so then we said, gosh, that's a lot going on with horses. 9 cases a year, and these are just the ones that are reported. So what are our equine farmers thinking? What are some things that they are doing? What do they know about this? And so for our survey, we had about 24% response rate. Most of them said, I am aware of vaccines for our horses for triple E and West Nile virus. And so that was a really good thing, and a lot of them did vaccinate their horses, which were awesome. as I drive back and forth to school and work, there's a equine farm, and I always think about it now, especially I'm like, gosh, I hope they're vaccinating those horses. And as it's getting warmer outside, everybody's excited about this warm weather, we've got to be thinking, what comes with warm weather? These mosquitoes are coming out. And so this is really important that we're getting this information out to our equine farmers. Hey, now is the time to start thinking about vaccinating your horses, and do you know about horse vaccinations? And so it was really important for us to get this information out to them. And so most of them, and this may be because of those vaccinations, reported that they did not have any equines that had experienced Triple E or West Nile fever or neuroinvasive diseases for their horses. And so that was really, really good. And we do think that's because of the vaccines. And then we wanted to know, okay, if you did not vaccinate your horses, why is that? Right? And so some of the reasons were, and it's really, when I think about it now, and so for my doctoral work, I've done some COVID work in vaccines in humans. Some of these kind of aligned up to what I'm seeing now. Some of them said, hey, I don't think the vaccines work. Well, our data is kind of showing that it does because people who are vaccinating their horses don't see it. But that's understandable sometimes. You don't see it work. You don't think it works. It's too expensive. You got to think about how much this costs them to buy these vaccines or to have a veterinarian vaccinate their equines, right? So that's very expensive for them. And then for others, they did not believe that mosquito-borne diseases are an issue. And that is something that we see here in Eastern North Carolina. Because again, a lot of times when you think about mosquito-borne diseases, you think about tropical areas. And so here, our weather, we get all 4 seasons most times. Sometimes we get it all in one day. They're not thinking we have these types of mosquitoes that can cause diseases. And so we also wanted to talk about mosquito awareness for them. And so for really the ones that were knowledgeable about it and they felt that mosquitoes were, a problem, they thought, it is important to protect not only the equines but ourselves from mosquitoes too, which was really, really good to hear. Because at that point, we actually sent them out information about pest management and things like tip and toss. So 52% were concerned about mosquito-borne diseases, 20% were not concerned. But again, they still got the vaccinations, which was awesome. And so when we asked them, what are some things that you do to protect yourselves, we did get a myriad of responses here. And I'll show you that on the next slide at the table here. So most of them were things that we use at home, insecticides and pesticides. A lot of people are like, I spray, I put things out. Leaves. So a lot of people don't realize that leaf piles can gather little bits of water. One of the things, we work with a lot of students, so we do a lot of trapping, and we try to educate people in the area is a bottle cap. So we have these bottles of water here. That bottle cap, water gets in there, you can breed mosquitoes. And so we try to tell equine farmers, and they're listening with this survey because they're looking through their leaf and their leaf piles and they're getting rid of that debris and anything that can hold water, which was really, really good. And so they also look at drainage and things of that nature. But it was very interesting to see what they were doing to try to mitigate this mosquito exposure, which is awesome. And so what was our takeaway? One, that yes, there is a correlation between human cases and equine cases of Triple E. And so we actually saw this in another study in New York where there were 4 counties that were adjacent together, and they kind of saw similar transmission patterns. And what this said was when we're seeing these types of things, we do need some type of surveillance system that we need to get out and start using. And maybe we can use some type of animal or mosquito surveillance system. The downside of that is we need support. Right? So you just can't say you got to have surveillance, you got to fund it, you got to support it. Unfortunately, what we do see in the mosquito world is some of that support for local mosquito control programs is lacking in times of a budget crunch, though that's the first thing to get cut because it's cold when they're going through those budgets and you're not thinking about mosquitoes, so we get slashed. So, and we did some studies, and yet inadequate funding is a huge, huge, huge thing. In North Carolina, there was a study, 84% of those felt that their mosquito control programs needed improvement. And so if we're talking about we'd like for you to roll out surveillance systems and your program needs improvement, then how can you do that? And, our thing is, if you can get these surveillance systems in place, this is going to help because this is a serious public health issue. When you think about it, again, with your equines and in humans, think about the health implications. When you're talking about neuroinvasive diseases, think about what that does in hospitalizations and how it harms humans just mentally and physically. And so I just want to give you guys just a little bit of talk on that. Any questions?
Hi, really great talk, really amazing work, very interesting.
Thank you.
I'm kind of curious. So it seems that with your study, you really only stuck with equine with it, especially looking at ArboNet and with your surveys. Did you consider looking at other farms or other dead animals? Mostly maybe emus. Coming from Florida, we've had some issues with triple E and emu farmers and whatnot, and I know they're put into ArboNet, and just anecdotally, I feel like they would be even less concerned about vaccinating than, say, like maybe a horse farmer where it's a lot more investment.
The animal that we thought about was actually pets. So we thought about like chickens, because now, and it's, and the thing that brought it to my mind when we were thinking about, setting up this project is my pastor, they have chickens and they grow their own hens and, things like that. And so a lot of people are, locally sourced. I'm gonna grow my own eggs. And so that was the one other animal that we thought about, hey, are you guys, because it's transmissible, that's the cycle, birds. And we're having a lot of people, again, with chickens and hens. And so that was the only one. But that's a good one. Emus did not think about that. It's funny, they actually have like an emu at this horse farm that I pass. Yeah.
That was actually going to be kind of my question. In Volusia County, mosquito control uses the Sentinel chickens.
Yeah.
Were you able to get a hold of any Sentinel chicken data, or does North Carolina do it at all to start figuring it out? And then second question is, are you concerned potentially with the continued migration of the Aedes aegypti species that carries even more harmful viruses with it as it world's warming and getting further north?
We have a couple of counties that do work with Sentinel chickens. Brunswick County does it. We have a gentleman in Forsyth County that when he has time, he does it. It's just funding, unfortunately. And so the data, bless you, from Brunswick County, they're awesome down there with their Sentinel chickens, but we were able to use some of their data, unfortunately, because this was kind of North Carolina-wide. We couldn't take that and extrapolate it out for the whole entire county. But one thing that we are doing, particularly in our lab, is we partnered with some of the other local environmental health units that don't have surveillance programs. And so we've gone out and we taught them, and they're using BG Sentinel traps, and some of them use CDC light traps to show them how to trap. And they'll drive in the mosquitoes into us, and so I identify them and we pull them. And we're probably going to start in another month or two, and we pull them and we test for triple E and West Nile.
Fantastic.
Yes.
Didn't know that Sentinel chickens was a thing. That is like super cool. Did you, when you were looking at the changes and what you guys were finding every year, was there a particularly wet summer in 2012?
There was not. And that was the first thing I thought, oh, maybe it was the rain and, we would see it after that. And it wasn't. And I even looked after Hurricane Florence. So you remember they had all that rain down in the Wilmington area. And you would think we had a lot of mosquitoes. It was on the news. But the mosquito population that populated were flood-borne mosquitoes. So it was a lot of ciliata. And those aren't what we call bridge vectors or vectors for these diseases. And so for that reason, yay, great, but it still, hurts when they bite. But we didn't find that correlation with that particular, with those two particular diseases.
Okay, thank you.
Mm-hmm. All right.
So there's some themes that I'm sort of seeing here from this morning's sessions, and it's kind of tough to tie them all together. But there's a certain nature of the ability to educate once we're informed, and we've done pilot studies, we get ourselves educated and connected with the industry, the sector, the stakeholders. That knowledge and data and research from that gets relayed somehow, and sometimes that knowledge is relayed and we call it education, sometimes we call it outreach, sometimes it's an intervention or some other some other way of getting change to happen that has benefit. I think that what I'm thinking is that intentionality is an outcome. It's one thing that I'm not quite sure how to measure, but that, looking at leaf litter or for bottle caps or for places in construction sites that could be potential risks or hazards, that's a degree of intention, right? If you're trying to lose weight, if you're trying to change your habits, any kind of behavioral change, I think one of the biggest drivers of that is doing it intentionally, having a plan and sort of being intentional about it, and then using bite-sized steps to get there. I mean, that seems to be a human nature thing that seems to work across the board. And I've seen a lot of different successes and different modalities and different types of research applying that. So again, I think the big thing that we're striving to do is to make sure that our work has beneficiaries and that you can understand the benefit to those beneficiaries in the long run. And we're finding all kinds of interesting ways to come up with metrics. How much did they benefit? Did they benefit? And I think that that's a good common goal for all of us. So that ends our program presentations this morning. I'd like to give everybody a big hand from today and throughout the entire session. The quality of presentations here, both oral presentations and the poster presentations, I think have been really outstanding. So congratulations to all of you. I've really enjoyed hearing and watching and listening and learning and reading and interacting with all of you. We have a couple of things to wrap up with before we close out. And the good news is it's all good and it's all fun. So the way this works is that we have awards for posters, a first place and a runner-up at the master's level, a first place and a runner-up at the doctoral level. And then we also have a fan favorite poster. And so I'm going to just start off with the fan favorite poster. And that award goes... This is where everybody got to vote, right? Nicholas Neves from University for Embry-Riddle, inspection and final reporting at a manufacturing facility, changing the way we think and perspectives. Great job. And finally, I need a volunteer, someone who I don't know personally very well, to pick out a raffle ticket for us here. Here we go. And the winner, you have to be present to win. Sarah Gonzalez, are you here? Sarah! Pick another. You not only have to be present to win, but you have to write it in the English language. Interpret for me. Dumas. First name? Alexander Dumas? Perhaps? Andy Kane Dumas? If you think you're close to a Dumas, please do recognize this. Michaela, I saw you here. Where are you? Michaela. Even being in the restroom, we really can be a ding against you here. It's tough. We really hold to the schedule. And Acosta Soho. This is you? Awesome. Come on up here. Well, we need a picture. So you've won the raffle. Everybody has a chance to be amazing here. Everybody has a chance to win, and we are all winners, but we have a special opportunity here. Yadriana has won the raffle because it was good luck. There's no other reason for it.
Andy, you sound like
Okay. So at the master's level, second place award goes to Tracy Gates from the University of South Florida on her talk on burnout, job satisfaction, and turnover in Florida Departments of Health. Coming up here. There is obviously a certificate. That's the primary recognition. You get to stand up here, and most of all, have the satisfaction. There's also a monetary support that goes with that. Reinforcement and acknowledgement comes in many forms. We give you all of those and then some. At the master's level, first place goes to Christina Sanchez, our epidemiologist from University of South Florida, looking at clinical decision support tools for ultrasound diagnostics. My elbows feel better already. Congratulations. Great job. At the doctoral level, second place runner-up, Carolyn Eberle from University of North Carolina, for her poster looking at employer accommodations for women undergoing breast cancer treatment in the workplace. Great job. Last but not least, it's the only last award we got. First place for our doctoral candidate presentation, poster presentation award goes to Jacob Shedd from the University of Alabama at Birmingham, looking at the sampling rates and mass recovery of VOCs from diffusive samples. Congratulations. Great work. Great work to everybody. I'm going to turn this over now to Dr. John Staley, our host for this meeting, and I want to thank him so very much for his hospitality and his insights, and the woman who you've seen more of her back perhaps than you should have. I'm sure John will provide enough embarrassment for Emily. Emily McAdden, you've really been a phenomenal support system for our entire program development team and organizing team, and she's way too humble. So I'm not going to stop because you want me to. You got to learn to suck this up. A lot of this work was really done by a large team, and we're going to introduce them, or John will introduce them to you in a moment here. But Emily has really spent a lot of the time making it all come together for us. And let's have a round of applause for Emily, please. John, thank you.
All right. Thanks. Thank you, Andy. Yeah, well, thanks for coming to my home. I'm glad you could stay with me at the Rizzo. I appreciate that. But no, it's been really fun to be able to have this here and host this year. And we look forward to next year. And the planning committee was critical to this effort. That I think some are in the room, but folks like Alan and Paulisha from University of Alabama, Birmingham, Kelly, back there in the back, and Kathy from South Florida. Oh, yeah, she's in the hallway working. Julie Myers is out in the hallway from UNC. Of course, Emily. Andy from University of Florida. Ashley and Kristen from University of Kentucky. And so a large committee, a lot of work went into it, and it was a lot of fun to do it. One thing I want to mention before we head out, I've been trying to digest everything, and I know you get a lot coming at you in a short amount of time of really great, important research. And I was thinking about this I think I shared last night at dinner with some folks, but my wife is a third grade teacher, and like for every other teacher, the pandemic has been insanity. I mean, my wife is out of the house in the morning at 6:45. She teaches from 8 to 3:30, immediately goes into planning work till 5:30. She comes home and has a little dinner, and then she works till about 11 p.m. She does this every day. And it's been even crazier with the pandemic when we think about pivoting when they went online. As we know, school's dead. And teachers are not trained in online learning and creating online programs. And nor do they have the resources that we have in the universities when, it's not the most fun thing to do anyway, we know, when we have to take one of our courses and move it online. And then when they started shifting back to school, having to have a plan where you'd have full written lesson plans to teach in person, but also create online content at the same time and be ready to do that multiple different ways every day with different students, depending if they came to school. So I think I show that as an illustration, and I'm the one who vents for my wife. She takes it in such good strides. She's like, I love my job. Yeah, it's stressful, but this and that. And it's one thing I think about that. So how does this tie to occupational safety and health? Obviously, a lot of stress. And, in the schools, all the way through the university setting, we put the focus on students, student learning, student health, and that's very important. Very, very important. Don't hear me wrong. But that is predicated upon the health and safety and well-being of the workforce, the teachers, the educators, the emergency or ER nurses. So, we've got a lot to do, and I think it's a great opportunity. I am pretty much a glass half full kind of guy. Or the Cheez-It, Cheez-It box, if it's that's half empty with Cheez-Its. But anything else. But we know that the pandemic has shown us a lot here with the changing nature of the workforce. We think about some of the keynote speakers, whether the governor, Fletcher, or Sarah Tamer is talking about, the future of work. What's that going to look like? And with the changing, the gig economy, and workers retiring, and young people coming in with different expectations, what is that going to look like? And we know that well-being is critical to a stable, productive workforce. But at the same time, we've seen in here that your traditional, if you will, occupational safety concerns are still big. I was just thinking this morning with the construction hazards that Albert talked about, and still, that's such a dangerous profession. Or, eye protection that John Gua talked about, that still, things that we go, man, we've been doing a lot in this area for a long time. They're still there. So you might go, down. Well, we know, human behavior is a big player in this. But at the same time, we have an opportunity, I think, to continue working. I'm getting up on my soapbox, I think. I don't know. To continue the good effort we're doing here. And it's exciting to see all the work that you're doing. And one of my MSEAH is from ECU, so I like that, Avian. So it is really was exciting, and I wish we could do it longer, but yet I know we all have lives to get back to. But hopefully this has, I know it sounds cliche, inspired you to continue that good fight and generating the knowledge we need. And I know the old saying is knowledge is power, but no, it's knowledge sharing is the power. And creating that position for people that where we could build the equity that we know that's lacking in so many areas in this country. So it's awesome to have all of you here. I know there might be some hazardous weather this afternoon, so hopefully your flights will be safe. If you're driving, have I missed any parting announcements? Or? Get your posters. Oh, yeah. Please pick up your posters on your way out. And again, be safe, and thanks for coming.